Hello, and thank you for joining us for today's virtual education program at Cancer Support Community South Bay. I'm Rebecca, the program manager, and I welcome you to this workshop titled Understanding Care Options, Palliative, Hospice, and In-Home Support. Before we begin, if this is your first time joining us, CSC South Bay's mission is to uplift and strengthen people impacted by cancer by providing support, fostering compassionate communities, and breaking down barriers to care. Our vision is that everyone impacted by cancer receives the support they want and need throughout their experience. We serve the South Bay, Long Beach, and Orange County area all at no cost. Our program includes support groups, networking groups, healthy lifestyle classes, and educational programs like this workshop. Educational programs are open to all. If you'd like to hear more about our services or join our community, please visit our website at cscsouthbay.org. Before I introduce today's speaker, we ask you to keep your microphone muted to eliminate any distracting background noise. Please feel free to enter any general questions into the chat function found at the bottom of the Zoom window at any time. Without further ado, I'd like to introduce our workshop speaker. Marcella Miller is a seasoned healthcare professional and a passionate advocate for families navigating serious illness and aging. With years of experience in the hospice and home care space, she specializes in guiding individuals and families toward compassionate, appropriate care solutions. And she is currently the executive director at Salus Homecare. Thank you so much, Marcella, for being here with us today.
Thank you for having me, Rebecca. And good afternoon, everyone. I appreciate you taking time out of your day to be here with us. The purpose of this program and presentation today is to be able to share with you not just levels of care that are available to you, but maybe also what to expect during your disease process or even aging process, what levels of care you or your loved one may or may not experience at some point in time. So hopefully I can just clarify a lot of confusion that I have found through almost 20 years of working with older adults as they navigate aging and so many different diseases that come with that. And the very frequent questions that I get, because most of you have probably experienced this, or you currently are experiencing getting a new diagnosis or having a hospital stay, and then you're just dropped into this new diagnosis and you're kind of navigating this whole new world, and it's very hard to find guidance along the way. And here at Cancer Support Community, they provide a lot of that great support and guidance. And hopefully I can just be an addition to that. If you have questions or if I need to clarify something, please don't hesitate to put that in the chat. And Rebecca will help me, see that as I'm presenting. And hopefully I have a lot of ground to cover today. So I'm going to go ahead and get started, and I'm going to fix my screen. So I'm going to focus a lot on palliative care versus hospice care, but I'm also going to explain home health services and some caregiving or in-home care services as well. Because if we think of care as a spectrum, you may start off with a very basic level of care, and then you may progress through a very high level of care. And you may, that progression is not linear. It can be, bounce over here, bounce back, as people are very sick and then they get better and then they get sick again. And so there's no one way to navigate through all of these levels of care that I'm going to share with you, but they do kind of stack on top of each other almost in a linear way. So I'm going to do my best to explain it that way. And let's see, how do I advance? There we go. So for many, many years, the history of our healthcare system, palliative care and hospice care have been described as the same service. Those terms have been used interchangeably, and it's up until just very recently has there been a shift and a change in that. Palliative care is no longer the exact same thing as hospice and vice versa. And so I'm going to explain that a lot in depth. So palliative and hospice care together, there are many similarities and there are many differences. And so I'm going to go through that. And it can be very, very confusing. And I also want to give you a tip that many of your healthcare practitioners that you're talking with may not have quite caught up to this new trend that palliative care and hospice care are different. And really, that is coming from Medicare. Medicare has guidelines set forth of what hospice care is, and they're starting to set forth guidelines of what palliative care is. And so it's really born out of a need for patients who are navigating advanced illness and having multiple hospitalizations, multiple symptom management issues, that palliative care has been born. And so we're going to explain that. So palliative and hospice are considered to be models for quality, compassionate care for people facing a life-limiting illness or injury. Hospice and palliative care are both team-oriented approaches, and they involve expert medical care. And then pain and symptom management is a big part of that, as well as spiritual and emotional support. And so this is all tailored and centered around, both of them are tailored and centered around the patient's, their needs, but also their wishes during this advanced illness. Support is provided not just to the patient, but to the loved one as well. And so we'll talk about that. And at the center of hospice and palliative care, the belief is that each of us have the right to die pain-free, with dignity, and that our families will receive the necessary support, not just to allow us to do so, but even after we do so. And then care is provided around that team support. And so what that includes is physical, psychosocial, spiritual, emotional. What does that mean? That is a physician, a nurse that comes and provides care, somebody who comes and a bath aide that will come and help bathe someone, a chaplain to provide spiritual support, and a medical social worker who can provide a lot of emotional support as well as resources and planning. So palliative and hospice care are both looking at symptoms, and here's a list of symptoms that require some additional support, such as pain, shortness of breath, fatigue, anxiety, even depression, a lack or loss of appetite, nausea, constipation or chronic diarrhea, even agitation and bleeding. So let's get into what is palliative, what is hospice, and this road can be a little bit bumpy, as I had mentioned before, and not linear. So I also had mentioned this previously, but I love this visual because the very top graph shows how care has been historically provided, that someone is diagnosed with a very advanced illness. This illness may or may not lead to end of life, but it could, but anyway, it's a very serious illness. And then medical care has been, okay, we get this advanced illness prognosis, we provide life-sustaining or curative treatment until we just don't anymore, and then the hospice team comes in and provides comfort care. And that's often how many physicians, even hospitals, still approach this model of care today. However, we are trying to transition to a much more proactive, a much more advanced care model that really has the patient in mind as far as their comfort and quality of life. Comfort and quality of life does not need to be reserved for the end of life anymore. It can now be incorporated into the beginning of getting a very serious prognosis. And so as a person is receiving life-sustaining or curative treatment, this palliative program can come on top of that and provide comfort and improve quality of life. Going back to that list of symptoms we were talking about, it can help alleviate pain, alleviate shortness of breath, alleviate appetite issues. All of those symptoms are what we're looking to alleviate with palliative care. And then as that illness progresses, and if someone chooses to no longer pursue life-sustaining or curative treatment, that's when hospice care would come in. And so it's a really nice transition from palliative to hospice care, as you can see at the very end, very bottom graph there. And then there's a tapering off of care because there's bereavement services that are provided for the family and loved ones after someone has passed away. And so the goal is really to integrate care, palliative care, into curative treatment earlier in the disease process. So we look at a variety of diagnoses that we consider serious and life-limiting. This is not an exhaustive list, but when we're looking at palliative care specifically, it kind of falls into one of these categories. So cancer being a big one, but also heart disease, kidney failure, liver failure, and then some kind of neurological disease, such as dementia, stroke, Parkinson's disease, ALS, or MS. So here's where I think most people get held, hung up. Most people get confused on this part. So as you can see, all hospice is palliative care, but not all palliative care is hospice. And so I want to take a moment to really make sure we understand that, because as you are connecting with care providers, they may not understand this. As I said, this is kind of a new model, a new way of caring for a patient that is, I would say in the last 10 years that we've really been moving towards, but a lot of healthcare practitioners have not quite caught up to this. And it could be for a variety of reasons. Maybe it's just their experience with, they don't really do a lot of end of life care or even that much advanced illness care. People are living much longer lives, but we're living with many more comorbidities, we call it, right? Many more things going on with our health that we need to navigate care-wise. And so if a physician is just looking at one thing, they might not be looking at you as a whole. So it's really important to be able to do that. And so as you are, this really is for the purpose of you being able to advocate for yourself or for your loved one as far as what level of care is most appropriate for you and is in line with your wishes at this particular time or any time in your disease process. And so again, palliative care is very specific. And so here's a word of caution. If someone shares with you that they want to bring you on to, let's say, palliative care as a service, but they talk about it like it's hospice, that is a red flag, or that would just be a caution for you to be alerted to. I have found in the many years that I've been caring for folks is that a lot of people don't like to hear the word hospice, and they also don't like to talk about it. And so they might use a word that is less jarring, such as comfort care. But it doesn't exactly mean the same thing. And so I think it's really important to use terms correctly so that we all understand exactly what it is that we are signing up for or receiving. So let's get in more into what palliative care is. Palliative care is outside of the principles of hospice. It extends outside of those. It encompasses a larger population, and that population could benefit from receiving this type of care earlier in their disease process or their illness, right? No treatment, no specific treatment specifically is excluded from consideration. So when a person is receiving palliative care, they may pursue all the curative treatment that they want to pursue. So this is how I explain it to folks that I'm working with. They have their primary care doctor, and then around that they might have their specialist team. They might have home health services, which I'll go back and explain that in a minute. They may have a dietitian they see. They may have a whole slew of different specialists that are involved in their care. And while they are receiving care from those specialists, palliative care comes as an umbrella over all of those and acts as kind of the quarterback. Palliative care helps to coordinate care from all of those specialists, coordinate the discussion of goals, to coordinate what it is that our goals are, trying to improve quality of life, what symptoms are not being addressed that could be addressed with maybe better medication or different diet or things like that, while the person is receiving curative treatment. Maybe they're receiving radiation or infusions, and palliative care can still be part of the care team. Okay. Palliative care, I think historically, many people know it through an acute hospital setting, and they might call it a comfort care wing or protocol, and that would be considered palliative care in the hospital setting. And then, here is the big thing, is that funding in particular has challenges depending on the care environment. So palliative care is available to most people, but finding the palliative care team that can be provided through their insurance can be kind of challenging. And since palliative care is so new, my director described it to me this way. She said, if you have experience with a palliative care program, then you have experience with a palliative care program. That doesn't necessarily extend to all the other programs that are out there and exist as far as what they look like and how they provide care. Everybody's kind of making it up on their own for their company. This is how we do palliative care. So it can vary quite a bit from company to company. And that's mostly because it's newer and has not yet been as heavily regulated as, say, hospice care. So you can receive palliative care in the acute hospital setting. And so again, the symptoms that require hospitalization to manage, they may provide the palliative care there. Now let's talk about home health. Home health and home care. Home care is not on my slide, but it is a different level of care. There's home health and there's in-home care. Those two things on the surface sound exactly the same, or like it's interchangeable terms, but they actually mean two different things very, very specifically. So home health it refers to a skilled need for a person who is homebound. They're at home and they're receiving skilled services at home. And so most often people receive home health right after discharge from a hospital back home. They're getting, a nurse comes and opens the case, but then they might get physical therapy. They may get occupational therapy. They may get a nurse coming for wound care or some other need regularly. They may see a speech therapist, and they may see a bath aide. So there's a whole team provided for home health. And so when you hear home health or health specifically, that is insurance. Okay, that always makes me think insurance pays for it. So if you can correlate health with insurance, that will help you keep clear in your mind what home health is. It's skilled, and therefore insurance pays for it. You do not pay out of pocket for it. And if you go to the hospital multiple times, you're going to have a new episode of a home health starting up again.
12:20 p.m.
And then there's home care. Again, this is not on my slide, so listen carefully. In home care, it does not have the word health in it. In home care requires to receiving help in your home from a caregiver. And so this is not a skilled person. They are not a nurse. They're not a physical therapist, but they are a caregiver and have skills as a caregiver. But they help with things that are not considered skilled. They help with things like activities of daily living, if you've heard that term before. So helping with like bathing, dressing, using the restroom, making meals, laundry, driving you to appointments, things like that. And so a caregiver oftentimes may start at the beginning of a new disease diagnosis, a new illness, because somebody might realize, I'm having trouble getting to my appointments, or I need a little bit of extra help a few hours a week. That's when a caregiver comes in. But a caregiver can be with someone all the way through their illness up until the end of life. And through the end of life, caregivers work with folks while they're getting home health. So caregiver can be there, and then your physical therapist can come do their visit and leave, but your caregiver is still there because they may be there for a longer stretch of period, longer time than the physical therapist is. Going back to the home health for a second, PT, OT, they come for maybe a 45-minute visit 2 or 3 times a week at the most. And then that might last for 4 to 6 weeks. And then it's over, right? Whereas a caregiver, insurance is not paying for it. In fact, if you go to Medicare.gov, right on their website at the very beginning, it talks about how Medicare does not cover long-term care. And what they mean by long-term care is getting care in your home on a day-to-day basis for activities of daily living. In fact, they don't provide it in any setting, activities of daily living. Medicare just doesn't pay for it. So it is a private expense out of your own pocket. Now back to my slide here. So skilled nursing facility is a different level of care as well. It also has that word skilled in it, which means you're getting services like a nurse, a physical therapist, occupational therapist, but you require to be at a facility to provide these services. Now, let me give you a little insight. Over the last few years, studies have been showing that people get better faster when they go home and get skilled care versus going to a skilled nursing facility. If you've ever had experience going to a skilled nursing facility or had a loved one go there, then you are acutely aware that it is not a place anybody wants to be. However, the right skilled nursing facility, and they're not all created equally, does provide a really good service, that it has its place in time. And so if you have like IV antibiotics, or you have pain management that you're getting through an IV, or hydration, chances are that you are going to a skilled nursing facility for those specifically. However, getting palliative care while you are in the skilled nursing facility is going to be very, very tricky. I have not seen it too much happen just because of reimbursement issues, which means insurance issues, right? But if you are on home health and you are home and getting physical therapy at home, then absolutely palliative care can come and be part of that care team now. I hope that is clear. I know that this is tricky as I'm talking through this, so please don't hesitate to interrupt if you have some questions and need to clarify. So now we're going to talk about hospice. So that was palliative, here's hospice. Hospice focuses on caring, not curing. Hospice can be provided anywhere, at somebody's home, in a skilled nursing facility, even a long-term care facility like an assisted living or a memory care, or even those small buildings called six packs or boarding care facilities, all the same name for that. And so again, it focuses on caring, not curing. And so those skilled nursing facilities, oftentimes people may not want to go home, or they don't have the social support to care for them at home on hospice. And that's when a person may choose to go to a skilled nursing facility. You do need to have Medi-Cal in place to be able to pay the room and board for that. Now, eligibility for hospice services, it does depend on regulations surrounding the Medicare hospice benefit. Again, that is very well-known information. You can go on medicare.gov and read what those services are. And so most hospices are pretty similar. Okay, now we all have different ratings based off of our quality of care and how well we implement those, the services that we are supposed to provide. So we're not all created equally, but the service that's provided to patients is pretty much the same thing. If you have a hospice company that is promising you free caregiving with their hospice, that is illegal. Let me just tell you that. That is illegal. That's an inducement of services for someone to give a free benefit for you to sign up onto their benefit. Medicare has very, very strict guidelines that we are not to offer anything outside of the scope of practice and benefits that Medicare has laid out. And so a patient also, to receive hospice, they must have a terminal illness, or we like to call it a life-limiting illness. And if that disease were to take its natural course, a physician would give about 6 months of life left. Okay. And so this is also big in the news over the last several years. And in the state of California specifically, there's been a moratorium on new hospice licenses because we have a lot of hospices in this state. And anytime, and so this is something that people just need to be aware of as a consumer. That again, remember when I was at the beginning when I was talking about people calling hospice something different in order to maybe get around the fact that it's hospice? This is where we need to be really careful, because through the last several years, there have been some bad actors out there. There's not that many. Most companies out there are very good, are in this industry because they want to provide a service and they want to make a difference. But there are some bad actors who've gotten into this business who have been signing, providing hospice to patients who have way more than 6 months of life left to live. And most of the times it's years, but they might do a little, finagling of documentation and medical records and things like that to show. But of course, that's all coming to light. And so if you're truly not within that 6-month prognosis, hospice is not for you yet at this time. Palliative would be a better option, because palliative can help provide some of the benefits that hospice provides, such as helping to manage those symptoms and providing a team of people to help support you in your illness. And especially as your illness increases and you become sicker, palliative is great for that. But hospice is not until those 6 months, okay? Now, of course, Medicare covers, but most private insurance plans have a hospice benefit as well as HMOs and managed care plans, okay? So even if you're not yet on Medicare, there is a hospice benefit provided for you. We touched on this a little bit, but hospice can be provided in pretty much anywhere you call home. So if that is your own personal home, an assisted living, a boarding care, the acute hospital, and they're going to call that a GIP, general inpatient level of care, or even a skilled nursing facility. And then here's also something that's available to you. If you are on hospice and you're receiving hospice at home, but say your loved one is your primary caregiver for that hospice at home, and that primary caregiver needs a break, as many times they do, or there's a vacation or a family wedding or something going on that they want to attend, through hospice, you have a respite available to you. And that means that your hospice social worker can find placement in a skilled nursing facility. I think it's up to 5 days within a period of time to give your loved one a little bit of a break. And so that's pretty cool as well. So we've been talking about this a little bit, but I want to lay this out side by side for us to take a look at. So remember I said that hospice is appropriate, and really the Medicare guideline is 6 months of life or less. Palliative care can start at the time of diagnosis. So we're talking more like 18 months in advance, if not sooner, or if not more than that. Hospice cannot be given at the same time as curative treatment. So if a person wants to continue doing radiation or chemotherapy, hospice is not appropriate for them at that time. However, palliative care can be provided along with chemo, radiation, or other treatments. Hospice requires Medicare Part A to be waived for the terminal illness. So what that means is you cannot be on hospice and go to the hospital and get both of those services because they're both Medicare Part A. And Medicare will only pay for one service at a time. And so you can be on hospice and then decline hospice to be able to go to the hospital, and then sign back up onto hospice when you're ready to leave the hospital, but you can't be on both at the same time. Whereas palliative care does not require you to waive Medicare Part A. It's palliative can be provided in the hospital as well. Hospice is 100% covered by Medicare, Medicaid, and most insurance plans. Now, I am seeing, it says 100% covered, but I am seeing people who are younger than 65 who are on a private insurance plan such as United Healthcare or Anthem Blue Cross Blue Shield. There may be a copayment for hospice. And so that's something that a hospice company you're working with or that you're looking into, they can run your insurance benefits and tell you what your share of cost is and help explain all the financial aspect to that, if there is any. Palliative care coverage is in the home or assisted living. It does often require a homebound status and a need for skilled services. So let me explain that. In order to get palliative, oftentimes the insurance company wants you to also be having that skilled care at home. So physical therapy, occupational therapy, speech therapy, they want you getting that at home so that you can get the palliative care as well. So those two often go in tandem together. Again, hospice is usually provided at home or a home-like environment. And palliative care, it could be difficult to access in many areas, just letting you know. You can definitely get it at home, but in other settings, it could be more challenging due to insurance. So here is something very important. If you are navigating a serious illness, or you are the primary caregiver or loved one of someone navigating a serious illness, here are some things to look out for that could kind of signal to you which level of care might be best for your loved one or yourself at this time. Again, sharing this so that you have the tools you need to be able to advocate for yourself or your loved one. Hospice and palliative care have many similarities in this. If you or your loved one are having frequent ER, that's emergency room visits, or having frequent hospitalizations, that means that you have an advanced illness or an illness that is not being well managed. You're having symptoms that are not being well managed. And so there is hope for you in the form of either hospice or palliative care. If you're having frequent falls, especially if they're resulting in injury. I mean, I've worked with older adults for almost 20 years, like I said, and falls are very, very common. But falls are not a natural part of aging. I think we think that it is because we're so used to accepting them. But even with physicians, I have to advocate sometimes and say, just because they're falling does not mean that it's okay in old age. It's indicative of an underlying problem going on that we've yet to uncover. So we need to do more testing, more digging to find out, why is somebody falling so much? That is not a normal part of aging. And then also, falls are the #1 cause of loss of independence. So if you plan to live to an old, ripe age and be in your home and be as independent as possible, you want to prevent falling. And so again, if there are frequent falls, especially resulting in injury, there is an underlying condition or problem going on. It could be related to your advanced illness, and that's where palliative or hospice care could come in to help. Now, your disease is no longer responding to medicine or treatment. You could choose to do hospice at that time if you fit within those 6-month period of your disease taking 6-month course, or palliative care if you want to continue trying alternative treatments or any treatments at all. Palliative care can help with that. If you are experiencing frequent infections. Now, here's where the differences start coming in. If you meet the guidelines for hospice care, then that might be the time to refer to hospice. And I would say if you have all the above and you meet the guidelines for hospice care, that might be the best level of care for you at that time, especially if your disease is no longer responding to medicine or treatment. I think there's a slide about this in a minute, but studies have shown, oh, it's right here at the bottom. Yeah, studies show that patients live longer with hospice than without, especially when they're faced with a terminal illness. And so we have found, I have seen in my practice, working with people for a long time, some doctors are very proactive, is what I call it, and will refer to hospice as soon as they've met the top criteria. They're in and out of the hospital. They are falling and sustaining injury. Here's the big one. Their disease is no longer responding to medicine or treatment, and they meet the guidelines for hospice care. That is when I've seen proactive physicians or proactive family members start advocating to get a hospice referral, because their loved one is going to live longer with more quality of life, which is the most important thing. Being able to carry out some goals before they pass. So that is my thoughts there about hospice. Palliative care, again, when you're newly diagnosed with a life-limiting disease, a very serious disease, if you want comfort, but you also want to pursue curative treatments, you also want to be able to be hospitalized when you need to be. And, or if you are not yet ready to sign on to hospice, palliative care is there. Okay. Another way to think of palliative care may be a bridge, right? It can help be this bridge to hospice eventually. However, I do want you to know, spoiler alert, many people come off of palliative care. They may receive it for a period of time, and then their symptoms get better, their bodies, their disease responds to the treatments and the medicine, and they're able to come off palliative care for a long time. And then it's there again when they need it, if they need it down the line. Same with hospice. Sometimes people graduate from hospice. Okay, it's not necessarily a frequent thing, but it can happen. And so I guess my point in saying that if people graduate in hospice is that even though you may decide to sign on to hospice and get that level of care, you can still come off of it at any point in time. If there's a new drug that is approved, or there's a new study that you can be part of that's experimental, and you want to participate, then you can just decline hospice and go back to getting that medicine or treatment. So hospice, again, provided in any environment. Okay, home, skilled nursing, assisted living, all of those. Palliative is usually provided in an acute setting or at home. Hospice does not require homebound, require you to be homebound. You can be driving, you can be walking, talking. You do not need to be bound to your bed. And it simply is that your disease qualifies you. If it were to take its normal progression within 6 months, and of course we don't have a crystal ball, so we don't know. It's the physician's best guess based off of their experience with that disease, right? For palliative care, you do need to be homebound. You're getting skilled care at home, you're getting palliative care, they can come to your home. But I do know that there are palliative care programs that are outpatient as well, that patients have to drive to be seen. Hospice, all of your medicine, all of your durable medical equipment, and all of your supplies are paid for. So if you need incontinence supplies like pull-ups, wipes, bed pads, wheelchair, hospital bed, bedside commode, walker, any of those things, all of that provided for with hospice. None of that is provided with palliative care. With hospice, a big misconception is, hospice staff are not there around the clock. They come and do their visits, often like the skilled care does at home. And so the nurse or the bath aide, the social worker, the chaplain, they'll come and do their visits, but they may not, but they're not there for an extended period of time. They'll stay as long as they are needed to for that visit, and they may even come daily, but they're not there around the clock. And then with palliative care, there is not consistent bereavement coverage between providers. You have volunteers provided through hospice, and with palliative care, there is not a volunteer program, and there's not a bath aide that comes to help at your house either. It can, hospice, again, Medicare pays for it. Most insurances cover it. Palliative care, you may or may not have access to it. It could be very tricky to get access to. Hospice care, your loved ones have access to bereavement for 13 months after a person passes. And so that really is to help walk families through an entire calendar year of holidays after their loved one has passed. All right, so palliative care, advanced care planning. Here is another reason why people may choose palliative care, or what palliative care can really help with. It provides advanced care planning discussions, and so really revealing goals that are consistent with your wishes. Palliative care also helps to explain the seriousness of the illness, and can be considered, like I had said earlier, about 18 months before the end of their illness, about 18 months. And Again, frequent infections, hospitalizations. Again, when you may think about why palliative care, when palliative care may be good for you or your loved one, this is a great list for. And so oftentimes I'm talking with individuals who have a very serious illness. They even qualify for hospice, but they're not ready for hospice. What I can tell, mostly because they don't quite yet understand their prognosis, treatments available to them. They don't yet see the big picture, and palliative care really helps bridge that gap. They provide a lot of education as far as where you currently are and what to expect going forward as well. So advanced healthcare planning, it is a process. It is one that is best started earlier rather than later. The advanced care planning process is a conversation about what's important to you. What are your hopes and your goals, and what are your concerns about the future? What are your, and so with hopes and goals, I think of patients who maybe they have a trip that they want to do with their family. Maybe there's a family wedding coming up. Maybe they're really concerned about being a physical burden to their loved ones as their disease progresses. These are all things that are addressed in this advanced care planning conversation. What really with this, with your diagnosis, what are the limitations and the abilities? Let's talk about both so you can have a clear picture of what life looks like with this diagnosis. And then what resources are available to you as you're navigating this disease. And then even completing documents and making arrangements. So completing legal documents, so you have your ducks in a row there, and making arrangements as well. This is what I have found with advanced healthcare planning. This is really what patients need to hear from their healthcare professionals. And so these are great questions for you to have ready when you are walking into a doctor appointment, right? Or any appointment with anyone. You know, what is my current state of my diagnosis? What are threats to my well-being and functionality? And what is expected, the expected outcome or expected trends? What can I expect with this, with my current state, my current diagnosis? And then, of course, what are my treatment options? And with those treatment options, what are the benefits? What are the burdens? Likely results? Are there any alternatives? You'll be amazed, and I'm sure many of you probably have had this experience already. You'll be amazed that it really takes being proactive and asking these questions to get healthcare providers sometimes to slow down and walk you through all of this. So the benefits of this advanced healthcare discussion, advanced care planning discussion, pardon me, is that oftentimes people are choosing to stay in the home or community as opposed to being in the hospital because they've taken the time to walk through their goals, their wishes, and make a plan for that based off of their prognosis and possible outcomes. We are seeing that people are able to stay home or in a community setting for a longer period of time with a higher quality of life, and then it's lower cost to the healthcare system. So again, that's fewer hospitalizations, a lower intensity level of care, and then again, earlier hospice enrollment, which means as soon as a person is eligible to appropriately take hold of that beautiful benefit that can help support you and your loved ones for better quality of life. So I just spoke for a really long time. I hope I have not confused anyone, or yeah, I hope that it's clear that I realize that it might be clear as mud. So if you have any questions, I'd love for you to please ask them at this time.
No, Marcella, that was beautiful. I think you went so thoroughly, but just, so everyone understood the breakdown. And I'm happy that I understood 100% of that.
Okay, good.
Yeah, no, I appreciate that because it can be confusing. So we do have a question in the chat, and then we have a question live. So the question in the chat is, you had the triggers for palliative care slide, and one of them was frequent hospitalizations, and I think it said like 3 in a year, I believe. Is that different by state, or is this a general recommendation, or is that a law, or how does that kind of
This is no law, and it's mostly from experience and what we have seen. And so the 3 or more in a year is really just like a guideline of to have in the back of your head. That is, I think when someone is living with an advanced illness, 3 hospitalizations a year may not seem like a lot, but it actually is a lot. It's very traumatic to go in and out of the hospital. It's a big wear and tear on your system. Again, I've worked mostly with older adults, and so I'm seeing people who are older in age who have greater decline because they're going in and out of the hospital. Think about being in an environment where you don't get great sleep because the buzzers are going off, nurses are coming in and out of the hospital room. You're laying flat on your back, maybe getting up and walking a little bit, but you really are not, you're not in your best home environment where you are functioning at your best. And we also see a lot of hospital-induced psychosis or delusions, right? Where people can just kind of, it almost looks like dementia or psychosis behaviors that are just suddenly come on to someone who does not have dementia. Okay, you don't have dementia, but being in such a altering environment where the lights are always on and the buzzers are going off and being interrupted, that it can cause people to get very disoriented and very confused. And it takes a long time to regulate that once you're out of the hospital setting. And so, in my professional opinion, it is very jarring to go in and out of the hospital, especially if you're much older. And so, that's where palliative can come in to really help triage in a way, help prevent so many frequent hospitalizations by managing those symptoms at home.
Thank you so much. Um, there's someone online, Apia, if you want to ask your, yes. Go ahead, Apia.
Is there any way we could get the list of questions we can ask the doctor? I tried to write them down, but you went too fast.
Oh, I'm sorry. Rebecca, do you happen to share this with folks?
Yes.
Okay.
So everyone online, very bottom, this worksheet will be available. So you can rewatch it. All right, we have another question. You mentioned that hospice companies cannot offer free services. What are the differences between hospice companies that one may look for if all the services are the same?
That's a great question. So, one, there is a lovely tool on Medicare.gov, and it's called Care Compare. And any facility or organization that is offering services that they are reimbursed by Medicare, they have a rating on Care Compare. And so you can go on there, and if you're shopping hospice agencies, you can just search the ones that, if often doctors are going to have one or two that they work with that they're going to recommend to you, which may be fine, but also know that there's many doctors who have a financial incentive working with hospices. It's not illegal, but I just want you to be aware of that. And then secondly, you might get several referrals from a hospital stay. So you could get referrals from anywhere, and then you can take those names onto Care Compare website and look up their rating. And that rating is based off of family feedback, because Medicare surveys the heck out of people about what was your experience like, which is wonderful because as an agency, we get all of that feedback and it helps us make changes and implement. So yes, we might all provide the same services, but how we provide them are not the same. And so also we get graded on our quality of care. So how quickly are, it's things like, was the patient in pain when they passed away? How quickly is the agency responding to calls from the family? Does the family feel like like their questions were answered and they knew what to expect, or were they blindsided? So it really gets very detailed into what we're graded on. And a big piece of it is our nursing and medical side of the quality of care that we provide. And so I love that question because I think consumers don't know that they can shop. And you don't have to go with who the hospital or your doctor recommends. You get to choose. And even if you're looking at a skilled nursing facility, go to the Care Compare. Home health agencies, Care Compare, they're going to be on there. And if they're not on there and they don't have a rating, then that tells you something too.
Thank you. I put that into the chat, but if you just go Google Medicare Care Compare, it does come up. So another question, can one change hospice companies if one is not pleased?
Yes, you can. It's actually a very simple change. You would find the new company that you want to go to. You can always have a consultation by them before you sign up. And here, kind of going back to the last question too, to answer that more fully, is when you meet with people, they should be able to answer your questions. They should make you feel really good about the care you're getting, and they should be able to explain to you what to expect. And if you have a sense of, I trust these people, I believe that they're giving me good answers, you should also be meeting with a nurse initially, is who should be the person coming and doing that evaluation, not a sales representative, but a nurse, because that is actually that is a legal requirement, is that a nurse is meeting with you, not a sales rep. And so you would meet with the new company and then they would initiate that transfer. They actually would reach out to the company you're currently on and say, hey, they're wanting to change companies. And then they would switch everything over. And it's pretty simple and straightforward.
Wonderful. Thank you for that tip about having a nurse there. This was just a wealth of information, so I do appreciate all the time and effort you put into this, Marcella. It does show how much you care and how knowledgeable you are about this confusing and fairly new topic. If there are any questions, please feel free to put it into the chat. Um,
And I also would like to offer you guys, anyone is welcome to reach out to me on my personal email or my phone. You can call our company. I'm happy to answer any questions that you have. That truly is my passion, is just helping to guide folks through just navigating, the decision-making process and what's available to them and what to expect. So I'm happy to answer any questions.
Absolutely. So we can use that Medicare for the care compare for hospice and skilled nurse facilities. But are there any standard palliative care things that you should be asking about or looking for?
Palliative care things. Yeah, palliative care is a little tricky. Like I was saying, it's not yet that regulated. And so I think I would like to, if I was in the shoes of shopping for palliative care, one, you might not have many choices just based off of your insurance and who is contracted. But you do want to look for, it's typically either a nurse practitioner or a doctor who is implementing the palliative care program. And then I would just ask for clarity. Is it an outpatient or at-home program? Do I need to come to you at your clinic, or do you send somebody to my home? And then asking like how frequently. Right now, Medicare's guidelines is a nurse practitioner visit 1 time a month. But I know for like our company, you have access to that nurse practitioner kind of at any time. And then we have a triage line. And so, but again, each company kind of implements their program a little bit differently, but the minimum is a once a month visit. And then you may ask as well, do you have a medical social worker that I have access to, or access to a chaplain? What if I have a call or a need nights or weekends? How do you handle that? So those would be good questions to ask as well.
Great advice. Thank you for sharing and again for all that wonderful information, Marcella.